Right. Can you hear me? It's okay. Yeah, so sorry about that. We had a bit of mix-up with the slides. So good afternoon to you all. We're here for the second section on cranial nerves. 7th and 8th, I've clubbed them so that it's easier, to remember some of the details, because 7th and 8th run together in the brainstem, in the CP angle. And then if we finish this well in time, we can do a bit of lower cranial nerves and see how that goes. Yeah? So the 7th nerve, we begin with the 7th cranial nerve, the facial nerve. This was one of the first cranial nerves that I realized that has a whole book on it. And when I was a medical student. And there is so much information on this nerve. There are several books on it. There are books on specific techniques, surgical techniques. There's a lot of stuff out on this nerve. And it makes sense. The reason is probably because the facial syndrome of a facial nerve, the clinical syndrome, would be so distressing to a patient. So there's been a lot of research, a lot of work that's gone into how we can prevent problems with the facial nerve, and then how we can do reconstruction procedures with that. So that would explain why there's so many books on that. Now, the facial nerve is a mixed nerve, right? It's got motor, sensory, and parasympathetic parts to it. So, yeah. So remember how the facial nucleus is located inferior to the abducens nucleus, and the fibers go medially, superiorly, and they curve around at the internal genu. When they come out, there are also fibers which are joined by the superior salivatory nucleus, okay, and the nucleus solitaris. Now, at some point, the superior salivatory and the nucleus solitaris kind of form one diffuse sensory nucleus in the medulla. Now, these fibers all come out as a single nerve, okay? And then you've got different branches. So the facial nerve supplies the lacrimal gland over there and is responsible for your tearing. That nerve also supplies branches to the nasal mucosa, a little bit of the palate there as well. And then you have parts of the facial nerve which go down to the submandibular ganglion, and then they supply to the sublingual and submandibular salivary glands. Okay, these are the parasympathetic fibers. Also, you have the chorda tympani, which goes to the anterior 2/3 of the tongue and subserves the function of taste. But by far, the most important aspect of the facial nerve is the muscles of facial expression that it innervates. So the nucleus of the motor nucleus of the 7th nerve has two components. It has a dorsal component and a ventral one. And why I'm stressing on that a little bit is, okay, we'll come back to that. All right. The dorsal component has got a different innervation, supracortical versus the inferior one. We'll talk a little bit about that a little later. Now, if you look at the course, the facial nerve leaves the pons in a lateral direction, along with the vestibulocochlear nerve. And it eventually ends up in the inferior auditory meatus there. Now, it has a long segment where it travels through the temporal bone, okay? And there it has what is called the external genu. So we have the internal genu which goes around the abducens nerve, abducens nucleus, and then you have the external genu in the temporal bone here. So that's how the facial nerve comes in, and then you've got this ganglion here, which is called the geniculate ganglion, because it's at the genu of the facial nerve. And you can see the long long course of the facial nerve within the bone. It actually makes it more susceptible to conditions where you can have diseases which can affect the bone. For example, you can get an infection of the mastoid bone at the back here, right behind the ear, in mastoiditis, and that could affect the facial nerve. So there are various surrounding structures which can cause problems with the facial nerve. And most of the connections that it has, parasympathetic connections with the other nerves, all that occurs at the skull base here. You need not know about all the details of this, but I just put this slide up to show you the intricate anatomy that's there within the bones of the skull base. Now, the facial nerve has two kinds of branches. It branches before it exits the foramen, the stylomastoid foramen, and it has branches after exiting. Now, the branches after it exits the stylomastoid foramen are all the branches which innervate the facial muscles of expression. The ones before are different kinds. So you have three basic branches here. The first one is called the greater petrosal nerve, or the GSPN, greater superficial petrosal nerve. You don't need to know too many details about this, but it's an interesting and important nerve which runs in the base of the temporal bone. And surgically it's important because sometimes tumors can be there, and when you try to yank the tumor away from this nerve or from the temporal base, you can have a facial nerve paralysis, and which seems uncanny because that's not where you expect the facial nerve to be. But because of its connections, you can get a facial nerve paralysis during surgery because of that. But you must remember that that nerve, it supplies parasympathetic innervation to the lacrimal gland. Now, you have the other nerve, which is the chorda tympani, the taste nerve to the anterior two-thirds of the tongue. But in between these, you have an interesting and important nerve called the nerve to stapedius. And the nerve to stapedius, it supplies the stapedial muscle, which which has a protective function. So when you have a it subserves the stapedial reflex, which is difficult to test clinically. But what it does is when you have a loud sound, a sudden loud sound, it sort of contracts the muscle and prevents the ossicular chain from transmitting that energy to the inner ear. And hence it has a protective function to prevent any kind of damage from sudden loud sounds. And we sometimes see that as a function which is that reflex which is lost in facial nerve disorders. Once the facial nerve gets out of the cranium and comes out of the stylomastoid foramen, it gives out a number of branches here which supply all these muscles of facial expression. We don't go into the details of that. I'm sure you've covered that in anatomy, but this is a simple way to remember the nerve, the branches, the main branches. And the temporal branch is actually very interesting because this is the one that supplies the forehead muscles, and you can see that this one is the one that is spared in a UMN facial palsy. We'll look at that in a little bit more in detail. What is interesting here is it passes in very close proximity to the parotid gland, through the parotid gland, and it can be involved in facial tumors as well. So there are so many different levels at which you can get a facial palsy. You can get it because of problems with the ear. You can get it with problems of soft tissue tumors in the parotid gland. You can get it with skull-based tumors. So multiple areas where the facial nerve can be involved. Now this is what I was talking about. So this is probably the most important aspect of the facial nerve innervation. When you have the corticospinal, corticobulbar tracts which come down and act as upper motor innervation for the facial nerve, the innervation for the upper part of the face differs from the lower part of the face. So the upper part of the face, which is subserved by the dorsal aspect of the facial motor nucleus, which supplies the temporal branch, right? So dorsal part of the nucleus, temporal branch, this has double innervation. So whenever you have a supranuclear lesion, that is a lesion above the facial motor nucleus, you will get involvement only of the lower half of the face on the contralateral side. And when you have an involvement of either the nucleus or the facial nerve itself, you will get involvement of the entire half of the face, because the double innervation doesn't help there. It's only up to the nuclear level, right? So this is a very important distinguishing feature of UMN versus LMN facial palsy. It also has very important clinical implications. If a patient comes to you with paralysis of half the face and they're in a panic mode, saying that they're having a stroke or something, and if you see that it's not if the upper half of the face is involved, especially the eye, it's more typically a Bell's palsy rather than an upper motor neuron. So even from points of view of your diagnosis for which patients would you like to do a CAT scan or an MRI, it helps to differentiate this clinically. This is about the same thing, just depicting the tracks a little bit more in detail here. So this is important to remember. So in an upper motor neuron lesion, you will have paralysis of the lower half of the face on the contralateral side. In the lower motor neuron, you will have paralysis of the muscles of both the upper and the lower halves of the face. Now, this is an important point. I'll show it in the next slide, but it may not be so important from the exam point of view. But in a UMN lesion, you can get two types of palsies. So you can get a voluntary palsy, and you can get an emotional palsy. So we'll come back to that slide. So if you look at this, and if you ask the patient to show her teeth or something, and you will get this very obvious facial palsy with a deviation of the mouth. But if you were to tell the patient a joke and they laugh spontaneously, you would probably not notice any palsy. Now, this doesn't happen in every patient. It can happen in some people, and it has to do with different tracts which innervate the facial nerve nuclei. And usually, it's the prefrontal region of the brain, along with some parts of the limbic system which get involved. So we won't go into the details of that, but it's an important point just to be aware of this. Now, in the upper motor neuron, you would get hypertonia, hyperreflexia. In lower motor, hypotonia, not very characteristic in a facial nerve. You can't really tell the difference with this so much. You can have associated hemiplegia on the same side as the paralysis. So if you have a cortical lesion like a hematoma or a stroke or ischemia, you would get weakness of the contralateral face, also the contralateral half of the body. But in a lower motor neuron, you may have a hemiplegia on the opposite side. So it depends on where in the brainstem that happens. So when we are doing brainstem syndromes, you will see that you can get a hemiplegia on one side and a facial palsy on the other side. So when you have these opposing signs, you know that it's probably a lower motor neuron. So these are just hints to identify lower motor neuron. You will have drooping of the angle of the mouth on the affected side. The nasolabial fold on the affected side becomes obliterated. This is a very subtle sign, and with someone having a very subtle facial palsy, this is an important thing to look at. And of course, the patient won't be able to show their teeth on the affected side. Now, all this is also valid on this side, but what happens in a lower motor neuron lesion is that the patient is more distressed about the eye closure. They don't care so much about the mouth. So the eye findings become predominant as a clinical syndrome. So this is something important to remember. They'll also not be able to frown. So that's the facial nerve in a nutshell. Very briefly, we'll look at the 8th cranial nerve. I know you've had classes on the vestibular, on the auditory system and things like that. So we will just look at it very briefly. This is again a completely sensory nerve, and it subserves hearing as well as balance. So we have the vestibular nerve.
Sorry not to interrupt you.
Sure.
So remember what it says, in facial nerve paralysis, would have not just a paralysis of the face, half of the face, but also they could have loss of taste sensation, and then, I mean, the two important things, and you could have both.
Yes.
Don't have to always have it, but look for that, and you can have hyperacusis.
I don't know where that slide went. 1 second. I thought. Yeah, it was there. Okay. Oh, it's gone lower down. I'm sorry. Okay. It's here. Yeah. Sorry. Well, so I'll talk about it when we come to that. So if you look at this diagram here, this shows you how the facial nerve and the vestibulocochlear nerve are related. When they leave the pons and run in a lateral direction, and they enter the internal auditory meatus here, both the nerves are in very, very close proximity. Now, the vestibular nerve has the superior division and the inferior division, and most of the tumors in that region come from the vestibular nerve. We will talk a little bit about that later. Now, just to look at the cochlear nerve in a little bit more detail, it originates, there are 4 order neurons. So it originates from the spiral ganglion, enters into the cochlear nuclei, which are here. You have 2 cochlear nuclei here. And then from this point on, there is a lot of bilateral innervation. So there's a lot of fibers crossing over to the other side. And yeah, so we won't go into the details of the olivary components and all that. But it's important to understand there's a lot of innervation on both sides. So when you look at a diagram like this, you can see that the red arrows indicate the cochlear division or coming from the left ear, and the blue ones coming from the right ear. And from this point onwards, you can see that it's red and blue all the way through. Now, why is this important? It's because unless, I mean, if you have a person who has a problem with the nerve here in the inner ear or in the cistern, you can get deafness. But once the nerve enters into the brainstem, it's very hard and starts ascending. It's very hard to get deafness. You can get problems with localization of sound. So that begins at the superior olivary nucleus, even below that, even at the cochlear nuclear level. But at the superior olivary nucleus, it becomes very important that this kind of a localization happens. So there are neurons which can detect whether the sound's coming from the right ear or the left ear, and the difference in the timing is what makes a person understand where the sound is coming from. So this topical localization is very important. Now, I used to operate a lot of patients with tumors in the temporal lobe or the insular cortex. And initially when I did this, it was very surprising because they may have other kinds of deficits, but they would never have a problem with hearing. Almost never. Yeah? You can get other symptoms from the cortex like tinnitus, which is a sound that they can hear, but you will never get hearing loss from these kind of tumors and things like that. So that's very important to know, and that's because of the double innervation, how the tracks go onto both sides bilaterally. Yeah, and this was what Dr. Ulal was talking about, the loss of the stapedial reflex and the hyperacusis. So this typically we see this in a facial nerve paralysis when there is involvement above the stapedial nerve, which exits in near the genu, the external genu. And anything which is below that, you will not have a problem with this. So if you have a problem with the parotid gland, you're not going to have trouble with the stapedial reflex because the nerve has already left the facial nerve, right? This is within the temporal bone. Now, so there may be an increased sensitivity or intolerance to certain sounds that you will see typically if the lesion is in that region. And that helps you kind of localize where the facial nerve is involved. So if you have loss of taste, you know that it's happening at a higher level because the chorda tympani is involved. So these are the 3 important things that you can remember: the stapedial reflex, the loss of taste, and the palsy of the facial muscles. I think we've covered most of this, but just a bit of a recap on this. So the vestibular nuclei, there are 4 nuclei. We don't go into the details of that. But the vestibular nuclei, you know, is associated with balance, with proprioception. So it has important connections with the cerebellum, the flocculonodular lobe of the cerebellum. I think all this will be dealt with in the lectures on cerebellum. We have seen how the vestibular nuclei has got connections with the MLF, medial longitudinal fasciculus, and the other cranial nerves, oculomotor cranial nerves, the 3rd and the 6th typically, and that helps in maintaining the image on the retina with movements of the head. And similarly, you have the vestibular nerve connections which go down as the vestibulospinal tracts to the spinal cord in order to maintain proprioceptive balance with the head, neck, and the trunk. Very briefly, we've discussed this. I showed you an operative video the other day about the cerebellopontine angle tumors, the commonest of which is a vestibular schwannoma. This was earlier called an auditory neuroma or an auditory schwannoma, acoustic schwannoma. but this was replaced by vestibular because further studies show that it's almost always the vestibular nerve from which the tumor arises, and mostly the superior vestibular nerve. So this has just been outlined here, the pons and the cerebellum, and this is where you see the tumor there, and that's the part which is extending into the internal auditory meatus. Typically, they present with vertigo and tinnitus, which is usually unilateral. The tinnitus generally settles down, as does the vertigo, within about a few weeks to a few months. It's not a very persistent symptom because the other side of the brain takes over. So you don't have persistent vertigo. But when these symptoms are generally coming down, that's when they start developing auditory symptoms. And that's the reason it was called an acoustic schwannoma, because most of these patients initially, in the initial clinical series, would present with loss of hearing. So it was considered as a tumor which arises from the auditory nerve. But that was found not to be true. And they're very, very slow-growing tumors, and they can be quite large by the time they're diagnosed clinically or radiologically. And the important thing is they're benign tumors, but they could compress the brainstem, because this is where they occur. They could compress the brainstem, specifically the pons and the cerebellum. Usually cerebellar signs are minimal. They're not so prominent, but you can have a patient face mortality based on the brainstem compression. So it's important to do something about these tumors as soon as they're diagnosed.
They can also have
Seventh cranial nerve, yes, yeah. Along with this, didn't mention that. Sorry. So the facial nerve palsies can happen. Usually, we see it as a very, very mild facial palsy when these patients present, because if they are a little sensitive, they come to the clinic with hearing loss or tinnitus, which is very disturbing to the patient. So the facial nerve palsies are typically quite mild, which actually get worse after surgery, because it's one of those cranial nerves which doesn't handle movement or dissection very well. So if you touch the facial nerve a little bit, you tend to get palsies. But there are alternative treatments like radiotherapies and things like that.
Why do you get facial? Yes, exactly. Very good point. Okay, that also comes out in the same region, right? The Vestibulocochlear.
Yes. So basically, if you look at the section there, if you look at the internal auditory meatus, you have these 4 notches there, which are separated by a vertical and a horizontal ridge. You don't need to know the details of this, but there are 4 nerves which enter the internal auditory meatus. So you have the facial nerve and the cochlear nerve, which are anterior, and the vestibular nerves, which are posterior. And all of these can be affected by a tumor in that region. Yeah. Yes. It travels, yes, so it's a branch of the 7th cranial nerve. So they're all traveling within the internal auditory meatus together, and as they're going through the bone, one of the branches is given out. So this is a branch which occurs within the temporal bone, and it's given out from the facial nerve, and it's very close to the vestibulocochlear. Yes. 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 So his question is, if you have the loss of the stapedial reflex and a person's having problems with this, having hyperacusis, there would be involvement of the auditory function. So why is that such an important thing, right? No, So yes, so the hyperacusis would be affected mainly in lesions of the facial nerve. But what I understand is you're saying if the auditory function is affected, why should there be hyperacusis? Is that right?
Because they're so close in proximity to each other, I would assume that.
Usually they can get affected together, but you can imagine a situation where the facial nerve gets involved quite separately. So you have a condition like Bell's palsy. So Bell's palsy isn't the typical term, Bell's palsy. Bell's palsy is a lower motor neuron affliction of the facial nerve. It's the commonest facial palsy that you will see. And it is not something which is associated with a tumor, say. So it will not affect the auditory or the cochlear nerves. Okay? It is just inflammation of the facial nerve, supposed to have etiological relation with the herpes virus, but it's not really proven even till today. So we see herpes virus in pathological specimens of the facial nerve and all that in people who have Bell's palsy, but the nerve gets a little bit swollen up, and that's one of the reasons, is because it's locked up in this little facial canal in the temporal bone. So there isn't much room for any kind of swelling. So if you have swelling of the nerve, it can get affected, but it has its own canal there. And it's not necessarily, it will not necessarily involve the eighth nerve, the cochlear-vestibular division, say in a Bell's palsy. So you could have loss of the stapedial reflex there, but you would have normal auditory function. And unless there's a tumor that's involved there, yes, then you could affect all the functions there. But if it's not a tumor, you can have isolated. Yes.
So from what you're saying, responding to his question, if the problem is inside the canal in the bone, that's where the stapedial
Yes.
nerve fiber from the branch of the facial nerve when it's running through the stalomastoid foramen in the canal, right?
Facial canal, yeah.
Before that, in the fossa,
then you can, yes.
What's happening inside the stalomastoid canal, then the chances are.
Yeah, once the branch leaves the facial nerve and the facial nerve's involved, then it will not happen. Like, yeah. Questions? Should we go on to the lower cranial nerves? Yeah. If you have a few minutes, can I just show the cochlear implants just for a few seconds? So this is an important concept, and I think you'll come across more and more patients with this. So for the auditory loss now, the earliest implants were maybe 60 or 70 years ago that William House came up with these little implants that you could basically amplifiers which would amplify sound and help in hearing for people who are going deaf. But people who have a problem with the cochlear region, it's very difficult to have these implants actually do much because there's a limit to which you can magnify sound. Yes. Now, I just put up this slide. It's important for two reasons. One, it's being done more and more commonly nowadays. And the second is that he's the person, Graham Clark. He's an Australian gentleman who came up with this, the current cochlear implants that are being used all over the world. And if you see this building, this is where I was doing my fellowship. It's in the same university. It was very inspiring to see this building. Whenever I walked down to my clinic in the mornings, I'd see this, and this is giant cochlear which is made on the outside of the building. So it's quite a historic building there, and it was interesting to see this every day. But what it basically does is they implant an electrode within the cochlea, and then you have a part which goes in, and there's a receiver, and this is internal. It's fixed onto the skull bone. And then you have an outside transmitter with an amplifier here. So then when a person hears some sound, it goes into the transmitter and it's transmitted to the receiver and then goes to the cochlea, and then that is transmitted into the brain. So it's quite an interesting concept, and it works quite well if you choose the correct patients for this. Yes? For someone generally who has who's almost completely deaf, with involvement of the cochlea more than the nerve. So you don't have to, in conditions of central hearing loss, let's say in the nucleus and all, there's not much you can do. They're coming up with implants for that, to implant within the cochlear nucleus, but I think that's some time away. Nobody's still doing that. But if a person has gone deaf with problems of the cochlea specifically, you can implant this. And they don't get, it's not 100% function that they get back, but it's quite useful hearing that they can get with this. And it's of course being modified and it's undergoing a lot of changes. So I think we can keep expecting newer and newer editions coming up. So, but it's a brilliant thing, and he's the gentleman who came up with it. So I just wanted to speak a little bit about that. Yes, so this is the final installment of the cranial nerves. We'll look at the lower cranial nerves. Basically, the 4 lower cranial nerves are the 9th, 10th, 11th, and the 12th. And why I've put this image up here is to tell you that the 9th, 10th, and 11th cranial nerves actually travel together, which go out through the jugular foramen, and the 12th cranial nerve goes out through its own foramen, the hypoglossal canal there. Okay, this is very important to understand. We'll do a little bit about the cranial nerves, not so much in detail, but just a general overview. So this is the glossopharyngeal nerve, which is a mixed nerve. Okay, so it has the motor division from the basal plate and the sensory from the alar plate. We know that already. What's important to look here is how you can identify it on the external surface. So this is the anterior medulla here, the pyramid, medullary pyramid, and that's the olive. And between the olive and the pyramid, you have the hypoglossal nerve which comes out. Remember, it's motor, so lies very close to the midline. And then behind the olive, dorsal to the olive, you have the glossopharyngeal, the vagus, and the accessory. All 3 nerve roots come out in that order. So it's the glossopharyngeal, followed by the vagus, and followed by the accessory. So the glossopharyngeal nerve comes out as 3 or 4 rootlets from the medulla oblongata, and it kind of goes laterally. Now, when we operate on people who have problems with the cranial nerves here, sometimes it's very hard to know which nerve is which. So usually it's the trigeminal and the facial which are different, slightly different hue in color. So the facial looks more gray, the trigeminal looks more bright, but that's something that's very subjective. But for some of them, you have an important landmark. And for the glossopharyngeal nerve, we have the flocculus of the cerebellum, which is a very important landmark. And just below that, you can find the glossopharyngeal nerve. So it's very easy to locate it there. Especially, this becomes important when you have tumors in that region and the anatomy gets distorted. So you're not sure what cranial nerve you're looking at there. And then you can trace them back, go to the part where the origin of the nerve occurs, and then you can identify it based on these landmarks. You also have the choroid plexus of the 4th ventricle, which just pops up there. And if you move the flocculus, you can see that, and you know that this nerve is the glossopharyngeal. Now, I put up this diagram. It looks very complex. You don't have to remember this. But just to mention one point here is this is the jugular foramen. And this is how the cranial nerves go right through it. You can see that's the 9th cranial nerve that goes in the anterior part, and then the 10th in the middle, and then you have the spinal accessory there. And they come down, and there's a lot of complicated interactions between these cranial nerves. And most of them, especially the vagus and the glossopharyngeal, run in this groove here between the internal carotid artery and the internal jugular vein here. So this is very important relationship to remember. So you have some of the muscles of the larynx and pharynx which are innervated by the glossopharyngeal. Again, details are not that important. Remember that the sublingual and the submandibular glands are innervated by the facial nerve, but the parotid gland is innervated by the glossopharyngeal nerve, which seems a little strange because the parotid gland is where the facial nerve passes through. Yeah? But remember, the parasympathetic fibers are much deeper, and the facial nerve which exits is purely motor. parasympathetic fibers are deeper in the bone. The glossopharyngeal nerve subserves a lot of important reflexes, like the carotid sinus branch, which helps in the carotid sinus reflex and all this, but we don't go too much into the details of all that. It has one important innovation which gives you, like, the entire face, and most of it is innervated for the basic sensations by the trigeminal nerve. We know that. But the glossopharyngeal nerve has some overlap for the external ear, the inside of the tympanic membrane, and the upper portions of the pharynx, and the general sensations from the back of the throat. Now, this is relevant from the anatomy point of view. Little difficult to test this clinically, except for the gag reflex, which we will discuss. So, the motor supply of the glossopharyngeal nerve is one small muscle, the stylopharyngeus. This is impossible to test clinically, so we cannot test the motor function. But how do you know that the cranial nerve is involved? One way is to check for the taste sensation from the posterior 1/3 of the tongue. Now, this becomes very difficult unless the facial nerve is already involved. Okay, you have some of these long segment syndromes which involve many of the cranial nerves. If that's the case, then it becomes easy to test for taste in the posterior third of the tongue. But if the facial nerve is intact and you have only loss, you want to prove loss of taste on the posterior part of the tongue, it becomes more difficult because the anterior part is intact and just the posterior part is involved. So the only way, interesting way to look at how you can identify glossopharyngeal nerve involvement would be by checking the gag reflex. I'm going to talk a little bit about that when we do the vagus nerve, because the vagus nerve is the motor component of the gag reflex. Most of these lower cranial nerves do not get involved in isolation. So you don't have palsy of the glossopharyngeal nerve, for example. It's not a common thing. You usually have them all getting involved at the same time in the jugular foramen. So you have the 9th, 10th, 11th, sometimes the 12th cranial nerve getting involved. And then there are many syndromes which have been named after these, exactly which component of which nerve is involved. You have a host of them. But there's one condition where the glossopharyngeal nerve is involved in isolation, and this is called glossopharyngeal neuralgia. So if you remember trigeminal neuralgia from this morning, it's exactly a similar condition, except that in the trigeminal neuralgia, you have the facial pain syndrome on the surface of the face and follows the 3 divisions of the trigeminal, the V1, V2, V3. But in the glossopharyngeal neuralgia, the pain is located very deep. It's a similar pain to the trigeminal neuralgia. It's in the tonsillar region, posterior pharyngeal wall. Usually the patient has difficulty isolating where the pain's coming from. But he says deep in the throat, it's episodic, lancinating kind of, shearing kind of pain, very severe. And then sometimes we do a similar surgery like the trigeminal neuralgia for the glossopharyngeal neuralgia. Basically, you have an artery there, and usually it's a branch of either the anterior inferior cerebellar artery or the vertebral artery, which actually loops around the glossopharyngeal nerve there. And that's separated out, and we put a little piece of muscle or Teflon there to separate the artery from the nerve. Yes, so vagus and glossopharyngeal nerve can be tested together, and they have similar functions in some parts, some part of the innervation. But I'm not sure if that's the reason vagus is called vagus, but I found this online. It's an interesting thing. And actually, like the city itself, it's very interesting in terms of the kind of different functions that it subserves. So it has varied functions, the vagus nerve, from the gag reflex all the way to the heart. Bronchoconstriction, peristalsis, reflexes of the gut, the gallbladder contraction. There's a lot of stuff that the vagus nerve subserves. Again, if you get a general idea of this, it's okay. You cannot test all this clinically. There are 5 important connections of the vagus nerve. It has its own motor nucleus, which is, let's see where that is. Yes, so that's the motor nucleus. of the vagus. And then you have, it also gets important connections with the nucleus ambiguous, the solitary nucleus, and also the spinal trigeminal nucleus. So 4 nuclei are located in the medulla. You don't need to know the details of this. But the nucleus ambiguous and the fibers which go from that into the vagus nerve are the ones that innervate the heart. So this is very important when you read a little bit about cardiology later. You will understand that it is related with some of the important cardiac reflexes, as well as causing bradycardia in a patient. Yes.
Patient that has inferior glossopharyngeal ganglion lesion,
Yes.
would they present with hypertension?
Yeah. Yes. So if they have an involvement of the inferior, yes, yes, yes. I don't think that is a typical clinical presentation that you get. No.
But they can come with they can have myocardial infarction like that.
That kind of picture can be there, but hypertension per se, I don't think so. The only association with hypertension, and I know this because there were important surgeries which were being done in the 1980s and 90s, especially from the US, they found, just like the trigeminal and the glossopharyngeal neuralgias, they found that sometimes on the lateral aspect of the medulla, inferior medulla, that's where the glossopharyngeal and the vagus nerves come out, you can have an arterial compression there, and that can be a cause of hypertension. This was thought of. Now, this is all experimental surgery which was done maybe 30 years ago. It's not been proven, but they would do the same kind of surgery, go and separate the artery out and put in some Teflon there, and the hypertension was cured. So that's the only hypertension-related thing, because I don't see any other way that you can have one of these cranial nerves being involved and have specific isolated hypertension. I don't think there's anything else that way. Yeah. But that surgery is outdated now, so nobody does that anymore. Yeah. So the vagus nerve. So all the parasympathetic glands in the gastrointestinal system is innervated by the vagus, except for the adrenal glands, and a lot of the muscles which are related to the lower facial part, especially the swallowing and the speech muscles. Many of them are innervated by the vagus nerve, okay, and the parasympathetic innervation to the heart. The right branch of the vagus is the one that innervates the sinoatrial node of the heart, and that has been implicated in a vasovagal syncope. Now, this is something that you will see when there is a sudden bout of excitement or anxiety, a person can suddenly collapse. And this is called a vasovagal syncope. It is generally self-limiting, and you make the patient lie down flat, and it passes over in a few minutes usually. And there are many other important and interesting pathophysiological ramifications on why this happens and all that, but I think that's beyond the scope of this talk, so we won't go into the details of that. Now, this is important. One of the most important things from the exam point of view is you need to know that the gag reflex from the lower cranial nerves, this is one of the most important reflexes, and the palatine reflex. So when you have a glossopharyngeal involvement or a vagus involvement, and usually they occur together, okay, you can have an impairment of the gag reflex. Now, if you remember, the sensory is from the glossopharyngeal nerve, so that's, you can have a mnemonic with that, and the motor is from the vagus. What happens is when you stimulate the posterior pharyngeal wall, the tonsils, the uvula, or the posterior tongue there, you can have a person gagging. And this is, although there are many other ways to, radiological ways to find if these nerves are involved and things like that, it still remains a very important clinical test, especially for patients post-operatively. So if I've operated somebody with a cerebellopontine angle tumor, the next day you would have somebody like a speech therapist or somebody go in and check for the gag reflex before we start the patient on an oral diet. And if you don't do that, he can choke or can aspirate, and all that stuff can go into his lungs, and that can be potentially life-threatening. So even today, this is a very important clinical test, not so much in a person who presents to you in the clinic, but rather, post-operatively. The other way to look at is to look at the palatal, the glossopharyngeal nerve, which helps in moving the uvula, and you can have a unilateral lesion which causes deviation of the uvula or palate to one side, and that can give you a hint of the involvement of the lower cranial nerves as well. Yes, please.
Would it be like the tongue where it deviates sort of the side that's low functioning?
I'm sorry, the tongue?
You know how you have dysfunctional cranial nerve like number 12, hypoglossal?
Yes.
The one that's functioning, the tongue deviates to that side when you're sticking it out.
Yes.
The uvula do the same thing?
The uvula, it does the same thing in, I didn't understand, I didn't follow that. What?
It would deviate. You said it would deviate to one side.
Yes.
Would it deviate to functional, the side that's not functioning? Or?
It would deviate, yes, to the side which is functioning, yes. And we'll talk about the hypoglossal nerve a little more in detail, because that's a more...
Isn't it opposite side? Because your uvula would go like this, right? You got the right.
If you have both the nerves,
Yeah. So you got this going like that, right? So supposing my right side is paralyzed.
oh, it deviates to the contralateral side of the nerve which is involved, yes. Yeah. Yeah.
Hypoglossal the other way.
Hypoglossal depends on whether it's UMN or LMN. We'll come to that later. Yeah, but the uvula would go to the opposite side, yes. The vagal, this is an important concept. I just wanted to talk a little bit about this. This has been around for about 25 years now. It's called the vagal nerve stimulator. And just like we saw in the DBS, we have a battery which gets implanted here in the chest wall, and you have an electrode which goes all the way into the vagal nerve here, usually on the left side, and the electrode is wound around the nerve like so. And this is very important in some people who have intractable epilepsy which is not controlled with medications. It's also being used for cases of intractable clinical depression. There are newer models out, again, like this one, which is a non-invasive vagal nerve stimulation, but they say that this one works a little better than the non-invasive one. So, okay. Oh, all right. I didn't realize that. No, we can do accessory and hypoglossal tomorrow. Is that okay? Yeah. And then we can do the brainstem syndromes with that after that. Because
See, even in normal subject, if you, for example, in ICM, you may have tried this for palatal reflex, ask the person to say ah and the uvula will see, the default state itself, it may be already deviated to the left or right. That's not important. So don't look at someone saying, oh, his uvula is deviated to the right, so has he got paralysis? No. Ask him to say ah, and when it says that, see whether the uvula moves equally. That's very important. Okay? So many times you see that when you teach this palatal reflex, students will say, oh, my uvula is deviated to the right. I don't know where mine is.
yeah, so there can be, usually there's some little variations, but it's the movement, like Dr. Ulal said, that's important. It's not just the deviation, so don't go by that. Yeah.
Okay. The question is,
Yeah.
tomorrow you are going to focus on 12th, in fact,
11th and 12th.
Will be done in another 5 minutes or 10 minutes. So what he is going to do, Dr. Dallan is going to do is you tell.
Yeah, so I'll focus on the brainstem syndromes. I think we'll have a whole talk on that, and then I think that will be done tomorrow, I think. And then if we on Friday, yeah, if we could
My
have,
question is what we are going to do Friday.
yes,
In fact, even tomorrow, syndromes will not take more than
half an hour,
20
maybe,
minutes.
half an
He
hour.
wanted to do 1 hour lecture, I censored it.
Yeah.
So if you see any slide there which says not important,
Yeah.
my censorship stamp.
Yeah, that's the red stamp that you see on the slides that's been put by Dr. Ulal.
Sorry, so Friday,
Yeah.
if you want, we can have a review. So if there's any question, you people have any concept that you want to ask, review on anything that was done so far, anything.
We could just have a general review on the entire brainstem or something like that. Yeah. Yes. Mm-hmm. Yes, it's close. It's relatively close. Yes, yes.
Would you say it's directed medially? I'm just trying to figure out, because it's saying it's in front of the ICA.
Yes. Let me show you that slide. Oh, you took it out? No, no, no problem. I've saved it here. I think it's here.
You can take it the microphone.
Yeah.